Hi, welcome to EDSC 520 Educational Assessment. It is week 6, so we are rounding off. Our group assignment is due this week, so hopefully you guys have that all together. This week, we're talking about chapters 14 and 15, the assessment with marriage and family counseling. And then also we're talking about chapter 15, and chapter 15 is on diagnoses. All right, so I'm going to just kind of go over that just a little bit and talk about some key points from chapter 14. Family assessments usually are done with a systematic approach. The approach is a holistic, and it's the focus and interaction that occurs and is not about the whole family, but really just how the family members interact and influence one another. The assessment would not be of a specific individual, but would focus on the dynamic patterns within a family and how they cope with it. So the family assessment is not done once to identify a problem, but rather the relationship status between the members. And as school counselors, we mostly focus on our client, just the K through university age. But of course, when we see somebody having difficulty with adjustment, we do have to take in consideration their home life and their environment. And is that impeding them in being successful in the school environment? And what is that environment like? And who are they around? So this is the relationship patterns that we're talking about. All right, so there are difficulties with assessing couples and families. The difficulties come with determining what should be assessed and defining it. The variables of assessment that are fluid and factual, interpreting the multiple different perspectives of the couple or the family, and developing norm sampling. So a lot of times, again, interviews are done, and this is the most common mode for understanding. In a previous class, you did a genogram. A genogram is an excellent tool to help understand the relationship patterns. Because again, the genogram is not like a family tree in which the ages and the numbers are, and the years and the names are important, but really the genogram is about all the relationship patterns, okay? Interviews can provide insights into the family dynamics and can corroborate by other different types of assessments, okay? There are mapping techniques, and it involves having families collaborate with counselors to geographically represent some of the pertinent representation. It's used for cultural backgrounds. That helps to understand where a person came from, their cultural dynamics within the household, all right? So we talked about how we use genograms. Also, family sculpting was discussed. It was originated by Virginia Satir, and it involves positioning either in the family members or objects that represent family in a physical space and symbolize relationships. So family sculpting is important. Families that have hierarchy systems would be good for the family sculpting. There's the EcoMap. It's used to gather information about larger contexts of families and homes. The observation and mapping activities should be used not as a sole mean of family assessment because of the problems with reliability and limited validity information. Instruments that are used for individual is the Myers-Briggs. We've talked about that. The MMPI, that is also a personality inventory test. So, and that helps to gather information about the specific individual that you're servicing, and then and using that in relationship to the family dynamics, all right? In marriage and family, they have premarital counseling and premarital personal and relationship evaluations that help. They have the marital assessments, such as the didactic adjustment scale, the marital satisfaction inventory revised, and the marital dissatisfaction inventory. And then they have other family assessment instruments, such as the family adaptability, the family assessment measurement, and the family environmental scale. All right, so that pretty much covers the information on family assessment. And in diagnoses, basically, it's important with diagnosing that we don't overdiagnose, basically. So the chapter talked a lot about 25% of American adults suffer from diagnosable mental disorders in a given year. And I was reading another mental health book that I think is excellent. I follow a gentleman, Dr. Amen. Dr. Amen provides a lot of great information about mental health and diagnoses, and his thought on the DSM-5. We use the DSM-5, and one of the things that he talks about in the counseling field is that we take a look at an individual and diagnose them based on the symptoms. And for the most part, most of the clients do fall into a category and can get a diagnosis. One of the things we lack is that we don't have something to look at the brain, a scan or a spec that is used regularly and that we're trained on to be able to see how the brain is functioning before we go ahead and give that final diagnosis or either start a treatment plan. So this is something that we do need to consider and think about, because that is something that we do. Like, you go to the doctor, your arm is broken, or you think it's broken. They take an x-ray of it. They see the bone. They see if it's a fracture, if it's actually broken in half. They see those things. I mean, if it's broken in half, it usually comes between the skin. But they get a chance to visually see it if they can't see it from the outside. We go on what people say, and sometimes it's hard for them to communicate to us exactly what's happening to them. So we make these diagnoses, and perhaps they're not accurate, or they don't tell the whole story about what's going on. There are cultural issues, and there's a cultural formation interview that has 16 questions in the DSM that helps with diagnoses. We also have the other specified or unspecified disorders that they use through the DSM and subtype specifiers. And the criteria for diagnosing is A, B, or C. It's specifically whether, specifically if, or specifically current and severe. Some of the common neurological diagnoses that are used that we see often in our area: autism, attention deficit, specific learning disorder, and motor disorders. Some other ones are schizophrenia, psychotic disorders, delusional, and psychoaffective disorders. Bipolar is also a common one. Some of those are manic, hypomanic, and major depressive. The depression disorders, which are disruptive mood, major depressive disorder, persistent depressive disorder, and premenstrual disorder. We have the anxiety realm, which is separation anxiety, selective mutism, specific phobias, social anxiety, panic disorders, agoraphobia, and generalized anxiety disorders. And then we have the obsessive compulsive, which is body dysmorphia, hoarding, hair pulling, and skin picking. And then we have the trauma and stress related disorders, reactive attachment, post-traumatic stress disorder, acute stress disorder, and attachment disorder. We have the dissociative ones: dissociative identity, dissociative amnesia, and depersonalization. And then we also have the somatic symptoms, somatic symptom disorder, illness, anxiety, conversion disorder, psychological factors. We have the feeding and eating, the PIC, the rumination disorder, avoiding restrictive food intake disorder, anorexia, bulimia, binging. And then we have the elimination disorders, sleep-wake disorder, sexual dysfunction disorder, and gender dysphoria. We have the disruptive impulsive control, oppositional defiance, intermittent explosive, conduct, pyromania, kleptomaniac. We have the substance-related, substance use disorder, withdrawal, substance use withdrawal, substance intoxication, gambling. And then the neurocognitive disorders, delirium, mild neurocognitive disorder, major neurocognitive disorder. We have the personality disorders, and these consist of enduring and inflexible patterns of personality traits. It's caused significant impairment in its social and/or occupational functioning, and it may not be evident in the first counseling session. And then it consists of 10 disorders organized under the clusters A, B, and C. Some common personality disorders: paranoia personality, schizotypical, the anti-social, borderline, narcissistic, and avoidant, dependent personality, obsessive compulsive, and the paraphilic disorders, okay? And those are voyeurism, exhibitionism, sexual masochism, sexual sadism, pedophiliac, fetishes, and transvest, all right? So those are the DSM grounds for medical model, and counseling is uses that in order to use those for diagnosis purposes. And as we don't have the ability to diagnose, but clinical counselors, other professions where you get more training, do have the ability to make those diagnoses. And those are extra master's programs that you can look into in the future. So again, for this week, chapters for week 6, you will have your discussion board, maintaining ethical standards, and your chapter assignment 4, which is your group's assignment of developing school counseling guidance. If you don't know how to do that, please go back to week 5. I did go over and show examples of a group assignment and what it should look like. Thank you so much.